Okay, the hilum is the blood vasculature that appears as white streaks fanning out from the center of the cardiac silhouette. It could be a normal vascularity, or excess vascularity, or decreased vascularity. The excess vascularity could be secondary to congestive heart failure or certain congenital heart malformations wherein you have an increased left to right shunting. Then you have undervascularity, which could be secondary to right to left shunting, meaning there is blood flow from the right to the left side of the heart bypassing the lungs, leading to less blood flow into the lungs and also decreased pulmonary blood flow. Now this chest x-ray shows you a normal pulmonary vascular pattern. Now, basically there are three pathophysiologic states that can be differentiated. First is your pulmonary venous hypertension or post-capillary hypertension, which is most notable in congestive heart failure, where there is a passive increase in pulmonary pressure through a valveless system. Second is the pulmonary arterial hypertension or the precapillary hypertension, which is the end product of many disease states with markedly different pathophysiologies. And the third is shunting due to congenital heart disease, which could be left to right shunting or right to left shunting. Now, in the assessment of the pulmonary vasculature, the lungs on the left side can be divided into inner thirds, middle third, and outer third. And in a normal pulmonary vascular pattern, the pulmonary vasculature or the pulmonary vascular pattern should be only seen in the inner and the middle third. And there should be no pulmonary vessels seen on the outer third. Now also, you can divide the heart into upper third, middle third, and lower third. And normally, the pulmonary vascular pattern should be limited on the middle and lower part of the lungs. And there should be no pulmonary vascular vessels seen on the upper third of the lungs. This next slide shows you on the left is a normal pulmonary vascular pattern. Take note that the pulmonary vasculature is limited on the inner and middle third and the second and lower third. Then for the increased vascular pattern, take note that the pulmonary vascular vessels extends up to the outer third, and also you can see pulmonary vascular patterns on the upper third. Now, also, you can also assess the pulmonary vascular patterns on the lateral view. Take note here, on the right chest x-ray, you have an increased pulmonary vascular pattern where there is exaggeration of your pulmonary vessels even at the back of the heart, whereas in your left chest x-ray lateral view, there is a normal pulmonary vascular lung fields. Okay, now, in this slide, you can see the decreased pulmonary vascular pattern wherein you don't almost see a blood vessel in the middle and the outer third. It's only concentrated on the inner third. And take note that in this x-ray, you have a bulging MPA segment. And also take note that there is almost no vascular pattern on the upper third of the lungs. Now here, on the lateral view, you see a decreased pulmonary vessels on the lateral view. Now in this next slide, you see pulmonary venous congestion as evidenced by the presence of pulmonary vasculature in the upper third of the lung segment as well as on the outer third. Here you have an increased arterial blood flow. Take note, there is evidence of pulmonary vascular markings even in the outer third and the upper third. Here you only have venous congestion wherein there is only vascular vessels in the upper and middle third, and second third, sorry. Now curly lines. These are thin linear pulmonary opacities caused by fluid or cellular infiltration into the interstitium of the lungs. And there are three types. You have the curly A lines, which the first is your curly A lines, which are longer, at least 2 cm and up to 6 centimeters, and branching lines coursing diagonally from the hyla out to the periphery of the lungs. They are caused by distension of anastomotic channels between the peripheral and central lymphatics of the lungs. Curly A lines are less commonly seen than curly B lines. Curly A lines are never seen without curly B or C lines also present. Now take note that the curly A lines are represented by the orange arrows. Curly B lines are thickened interlobular septae visible as 12 mm linear opacities about 3,060 millimeters long in the subpleural region. They are most readily identified at the scostophrenic angles on PA radiograph and substernal region on lateral radiographs. It is this indicative of interstitial pulmonary edema and are observed more frequently than curly A lines. Take note in this slide, your curly B lines is seen in the scostophrenic angle as horizontal lines. While in the normal chest x-ray, you don't see any horizontal lines on the scostophrenic side area. Again, take note of the evident horizontal lines as evidence as seen in the pointed black arrows. Curly C lines, on the other hand, are least commonly seen than curly lines of the curly lines. They are short, fine lines throughout the lungs with a reticular appearance. They may represent thickening of anastomotic lymphatics and superimposition of many curly B lines. So take note, the green lines or the green arrows is represented by the curly C lines. This next slide shows you the curly B lines evident on the right subcostophrenic sulcus. How about peribronchial coughing? Facial fluid accumulating around the bronchi. It causes thickening of the bronchial wall. It is a radiologic sign which occurs when excess fluid or mucus buildup in the small airway passages of the lungs causes localized patches of atelectasis or the lung collapse. This causes the area around the bronchus to appear more prominent on an X-ray. It has also been described as donut sign, considering the edge is thicker and the center contains air. Okay, when seen, it looks like little donuts. Cephalization. Cephalization is the anterogravitational redistribution of the pulmonary blood flow that occurs with heart failure. It is caused by increased vascular resistance in the dependent part of the lungs, a consequence of pulmonary venous hypertension, usually described on the basis of relative vascular size on chest radiography. Always remember that when you are taking a chest x-ray, when the patient is on upright position, because of gravity, there is movement of blood from the upper to the lower part of the lungs. Now, in the presence of congestive heart failure, because of increased pulmonary vascular resistance, there is failure of the blood to go down to the lower part of the lungs. Hence, there is what you call your cephalization. To emphasize, there is increased vascular resistance in the dependent part of the lung, which is the lower part of the lungs. This next slide shows you the cephalization. There is visible pulmonary markings on the upper third of the lungs. This next slide shows you almost white lung, which is evident of alveolar edema seen in patients with congestive heart failure. Now, features useful for broadly assessing pulmonary edema on a plain radiograph includes cardiac size or cardiac thoracic ratio, useful for assessing for an underlying cardiogenic cause or association, the buckling pulmonary opacities, the presence of peribronchial coughing, the septal lines, usually the curly A, B, or C lines, the pleural effusion, as evident by white segment of the costophrenic sulcus, the pulmonary venous engorgement or pulmonary blood flow distribution, the upper lobe pulmonary venous diversion. Okay, this next slide shows you an alveolar edema as evident by the almost white lung. Now let's go now to the great arteries. It's very important you need to evaluate or take a look at the great arteries, which is your MPA segment and your aortic knob. The question that you have to ask for yourself when evaluating the great arteries are they in normal position? Normally, the aortic knob is always on the left, and also the MPA segment is just below the aortic knob. Are they of normal size? Okay, the next slide shows you a normal aorta, which is on the left-sided uppermost in location. And also, you see the main pulmonary artery segment, which is normal. Now, the next slide shows you a prominent aortic knob. And the next slide shows you a diminutive aorta wherein you almost don't see, okay, the aortic knob. Now, the next slide shows you a prominent main pulmonary artery segment, okay. It almost displaces your aortic knob, and usually if you see a prominent MPA segment, it could be secondary to, number one, a large ductus arteriosus, or a severe pulmonary stenosis or severe pulmonary arterial hypertension, meaning your PA pressure is estimated to be 60 millimeters mercury and above. And take note here that the right pulmonary artery is large. Normally or ideally, the RPA should be of equal size as your tracheal shadow. If the RPA dimension is greater than the tracheal shadow, then it just means that you have an increased pulmonary pressure in the right pulmonary artery. Okay, the next slide shows you a normal MPA. The next slide shows you a concave MPA typically seen in congenital heart disease with decreased pulmonary blood flow secondary to a small PA or an obstruction of the right ventricular outflow tract or secondary to a pulmonary stenosis. This chest X-ray shows you a typical concave MPA seen in tetralogy of Fallot or also in patient with tricuspid valve atresia or persistent truncus arteriosus. Ancillary findings. You need to check for calcification, Vaughan deformities. Let's go now to ancillary findings. When taking a look at the chest X-ray, you have to note for calcifications, bone deformities, and others. Now, take note that the left clavicle of this X-ray film is fractured, and always remember that the most common fracture in children is clavicular fracture. Take note that there is discontinuity of your clavicle. Rib notching is an erosion of the inferior aspect of the ribs. It can be seen in some patients with correct tissue of the aorta. It results from a compensatory enlargement of the intercostal arteries as a means of increasing distal circulation. It is most commonly seen between the fourth and the eighth ribs. It's important to recognize this life-saving finding because aortic coarctation is treatable with percutaneous or open surgical intervention. This next slide shows you a density at the left lower lung field, which could be either be secondary to a pleural effusion or a mass in the left right lower lung. Now, ideally, the best thing to do in this kind of patient is right lateral decubitus. You let the patient lie on the right side, okay, and for 15 minutes to 30 minutes, then take a chest X-ray. If you see fluid after the chest X-ray is taken on the right lateral decubitus, then it is secondary to a pleural effusion. But if that white mass remains, it could be a mass in the right lower lung. Also, you correlate it with your P findings that when you do your percussion, it is dull on the right lower lung and there is decreased breath sounds on the right lower lung. Now, this is now a guide in interpreting a chest X-ray. First, is the film acceptable? Check for the name and date and the view, whether PA or EP view. Is it a good inspiratory film? Check for the exposure, the position, whether it is levocardia, dextrocardia, mesocardia, or dextroversion. Then check the situs, whether it's situs solitus or situs inversus totalis. Check for the CT ratio, whether it's less than 0.5. Evaluate the 4 chambers, the right atrium, the left atrium, the right ventricle, and the left ventricle, and take note of if there is enlargement and correlate it with your P findings. Then evaluate the lungs and your costophrenic sulcus. The ancillary findings, then give your honest interpretation. And this is the last slide, which is as the advised teaching skill in medicine. Take note, there are 20 things that you need to remember. Egg on its side appearance is secondary to an uncorrected TGA. Boot-shaped heart is tetralogy of Fallot. Box-shaped heart is Ebstein anomaly. The flash-shaped heart is a pericardial effusion. Egg-on cup appearance is constrictive pericarditis. Neumann sign or figure of 8 or Cotton-Loff sign is total anomalous pulmonary venous connection. The ducts or figure of 3, inverted 3E sign is coarctation of the aorta. The jug handle appearance is primary pulmonary hypertension, which could be secondary to an increase in your pulmonary artery pressure above 30 millimeters mercury. But always remember that in mild pulmonary hypertension, you may not see the jug handle appearance. It's commonly seen in patients with moderate to severe pulmonary hypertension. The Malady de Roger defect is a small VSD. The Hilar-Dance is atrial septal defect. The gooseneck sign is endocardial cushion defect or the AV canal type of defect. Then scimitar sign is the partial anomalous pulmonary venous return. The convex left heart border is the left transposition of the great arteries. Number 14 is the straight left upper cardiac border, which is due to Ebstein anomaly. Number 15 is the concave main pulmonary artery segment or right aortic arch, which is due to the persistent truncus arteriosus, which is like also your tetralogy of Fallot. Calcification of heart is carcinoid syndrome, and the cardiothoracic ratio should be less than 0.5. The lambda sign is a small ascending aorta in hypoplastic left heart syndrome. Severe stenosis is mitral valve diameter of less than 1 square centimeters, and the old disease is parchment right ventricle. Now, if on chest X-ray there is an interpretation of a possible congenital heart disease like tetralogy of Fallot, still the best choice to diagnose congenital heart disease or the gold standard in diagnosis of congenital heart disease is your two-dimensional echocardiography. If there is still doubt of the two-dimensional echocardiography, you can request for magnetic resonance imaging or the invasive type or procedure, which is your cardiac catheterization. And now, for the last slide, always remember, wherever you are, you should always carry the Lasallian Core Varius, which is Spirit of Faith, Seal for Service, Communion Ambition, and not mentioned here is your reverence for life. Thank you, and I hope you have learned a lot in this simple chest x-ray interpretation for children. Have a good day. This is yours truly, Dr. Rehente Aylapak, your friendly mentor, teacher, friend, and your colleague in the future. This is Dr. Rehente Imperial Lapak. When you are not with us anymore, feel free to communicate with me through Messenger or any form of communication. Magandang umaga, Animal Asal.